Let's get into it. Chris, thank you so much for joining us. It's been a pleasure to talk with you about your work, and I'm really excited for everyone to hear from you today. So I'm going to hand it over to you, Chris Kalsh, Executive Director, CEO at Winners Healthcare. Take it
Hey,
away, Chris.
good morning, afternoon, folks from Maine, afternoon. Good to see everybody. Although actually I can't see you, which is probably a good thing. When I'm talking like this, it's really nice to present when there's not an audience in front of you. Far less problematic for me, I think. As I go through, uh, please chat stuff, throw things. I love this to be interactive as I go. I really want you to get something out of it. So if I say something, you're like, how does that work? What do you mean by that? What's going on? Please just throw it out. I know Jessica will jump in and share that, and so I can hopefully respond in a way that helps out. I'm going to talk about Winners Healthcare. I think next slide. Let's do this. We're going to talk about AI, and you guys know why you're here. These are the topics. I'm going to talk about the why. I'm a big person on why you're doing something makes a difference. I think not only in how it goes, but it gives you kind of a sense of your understanding and kind of a grounded rock to move forward with. I'm going to just give you a quick background on Winners Healthcare, where we are and our size. I think that makes a difference in talking about some of the things that we're doing. It also makes a difference in where we're going from here and what we haven't done, which I'm going to talk about too, where we have messed up, what hasn't gone well, which people never usually talk about, but I'm glad to talk about that stuff too. That's how we learn, right? I'll talk about the AI tools that we are using now, and a couple that we're currently vetting in the next steps, and some of our concerns as we're moving forward, and then just really feedback and comments and hopefully some interaction on everybody's part. Okay, next slide. So for me, my AI journey wasn't, I'm not, um, right. I straddle baby boom and Gen X. I'm there. So I wasn't in AI in 2022 when Chat GPT hit the ground. I didn't start using it then. I'm not that kind of person. I started reading about AI, not using it, reading about it about a year later. And just uh kind of it didn't start with someone introducing something slick to me. It didn't come from there. It just started reading about what was capable. And then I just started dabbling in it and using it myself, and then realized the potential and the power that it had and the impact it could have for my organization. So it didn't start with a demo like it says here. It started with a realization that this could make a significant difference in the way we're providing healthcare and the way we're getting work done. And I'm in a rural area, and I'll talk about that in a minute. And that in a place where there's less resources, that AI had a potential to kind of impact and level the playing field for some of rural providers and the administration and the compliance and some of the other things that we have to cope with. Okay, next slide. So what's your why for AI? We are not, our why for AI is we're not implementing it to be first and to be slick, even though it is slick and it is new. Um, we're doing it because the same reasons we do most of we're doing it to improve patient care. I mean, that if we're not improving patient care, if we're not going forward with that, we're not meeting our mission. Um, Another big thing is obviously burnout. If there's health centers out there, that's what we contend with. We contend that with that. The whole health field does, and we especially do. So reducing burnout for staff was a big, and especially providers, is a big thing for us. And then promoting a work-life balance. If I'm going to retain staff, if I'm going to keep staff, if I'm going to be able to hire providers in the future, a work-life balance is something that we think is worth it. So next slide. Winners Healthcare. This is our mission, providing compassionate care to improve lives and inspire health as partners with our community. Next slide. Um, okay, so for those of you in Maine, I saw Texas. This is a ugly map of Yolo County in California, which is probably about 70 something miles northeast of San Francisco. That kind of mess to your right is Sacramento, where it has all those H's for hospitals. And probably about 20 miles west of that in the middle, 916 is Davis, California, where there's a university. And then about 15 miles west of that, of the purple dot, is Winters. We are considered rural by HRSA and by those standards. Um, we are backed against a mountain. We are at the edge of the Central Valley in California. Um, we have a big agrarian population, a lot of orchard, a lot of row crop, a lot of ag drying, processing, those kinds of things. Our population is around 75% um, Latino. At the health center, and the town itself is a little over 50% Latino. So that's kind of Winters. We have a satellite site which is north about 15 miles, Cape Valley. So just so you know, that northern brown swath in the uppermost corner, to get to that first purple dot there is probably about 40 minutes on back roads, and then get down to us is another 20 minutes. To get to Sacramento is about 40 minutes. So I'm not rural, but that is considered rural, and that's where I'm at. So you got an idea. All right, next slide. This is the building we're in. This is our main campus. This is Winters Healthcare. It was built, we occupied it in 2019. We were in some brownstones downtown before that. Next slide. And our other satellite looks like this. It's part of a community health center up in this town. So we're only on half that side. The flat side, that is where there is dental, pharmacy, behavioral health, and medical. The other side's kind of the community center and other nonprofits. So that's where we're co-located. Okay. This is my organization. I'm about 13 million annually. There's 83 employees. We started with 5. So over the last 20 years, we've grown. We do about 23,000 visits, around 5,000 patients. I'm sorry, 20,000 visits, 23,000 or 20,000. Look, it's in there both times. So it's not 43 altogether. It's closer to 23, just so you know. And we are an FQHC. We've been one since 2005. We are a 501c3 nonprofit, and we are rural, agrarian, and mainly Latino population. Okay. So the AI timeline for us. The first thing that we started with AI was actually a quality improvement project. We started AI with looking at one of our quality metrics that we had to meet was retinal eye exams for folks with type 2 diabetes. Right? They have to get an eye exam once a year. We were referring out for that. So you make a referral, they go out, they go see that person, special cameras, they take it. That comes back. Hopefully they make it there. Hopefully they get seen. Hopefully that person will accept a sliding fee scale or will pay for them, right? And it comes back. Having that in-house with a camera makes a huge difference. So the idea that we could actually do this in-house, not necessarily even during a visit. It could be they could come in at any time. It takes about 10 minutes to do this. An MA gets trained on it. They train the other MAs to do it. Um, and that was kind of our first venture in, and that was in March of 2024. After that, we did some administrative stuff. We started using Copilot associated with Microsoft 365. I don't know how familiar you are with that. It's gotten better as time has gone on, but we did that because it was kind of embedded, a product embedded within our software for subscription. And so we did that. Our clinical wellness, a bridge, ambient AI started in July of last year. So it'll be a year coming this July. And then the latest thing we're working on is patient retention through a ThriveLink, which is a AI application to help folks keep enrolled on Medi-Cal and link them to other kind of social resources. Okay, so I'm going to just go over each of these briefly. So that is a picture of our Luminetrix camera. Why did we go with this? We went with this not because it was AI. We went with this because it was a self-contained unit that was reasonably priced that we could do in-house and had everything there. It was also already FDA approved. In other words, it was, I think, one of the first FDA approved AI tools that was out there. So we didn't have to, we knew it was okay to use. We knew we weren't going to have any problems with it. In terms of vetting it, we knew it was tied directly to a quality improvement metric that we were going to use. It was training staff. We weren't taking providers away. And it was saving staff time and energy. It was kind of like low-hanging fruit, right? We didn't get into AI to get into AI. We got into AI because, oh, look, here's something that we can do that makes our life and our workflows easier, and it's better for patient care. It diagnoses within 10 minutes. If you have issues, it's terrific. If there's some problems with the shoot, it'll reshoot you. It's a sunk cost. It doesn't cost anything. They're digital images. So it's a great tool. We're continuing to use this downstairs all the time. So this is where we started. All right, next slide. Um, this is kind of a break in between, but it's germane to what we're going on. Um, we started a strategic planning process um, following the implementation of that AI. And one of the things that came up was retention and recruitment is one of our biggest challenges, external threats. And so one of the things we looked at was piloting a 4-day work week. We had been talking about it, but we didn't know anyone that was doing it. So I just want you to know that a 4-day work week, we started in June of 2025 last year. The idea is that it would help with burnout, it would help with um, uh, recruiting providers, retaining staff. And the preliminary research we showed that you could keep the same productivity. You would have better work-life balance, employees would be healthier. So we went for it. And I'm going to talk about this probably at a different time with our health-centered control network and our primary care association. We're going to do some presentations this year. We've been doing it almost a year, but just so you know, 4-day work week for us means 32 hours a week is full time. You get 100% of your pay at 32 hours. Um, we're working at 100% productivity. Most teams either have a Monday or Friday off. Um, we're currently in month 10, moving into month 11, and we're tracking about 40 metrics. So the reason why I'm bringing this up is because when you move to a 4-day work week, what we wanted to do is streamline some of our administrative tasks. So the next AI that we were looking at helped do some of that for kind of our 4-day work week and our administrative folks. Okay, so next slide. So Copilot, Microsoft 365 Copilot is another AI. If you're familiar with it, it's embedded within Microsoft 365. You do have to pay extra for it because you always have to pay extra for something, right? Nothing is ever free. 80% time at work means in the office, 80%, 20% remote where it might make sense, say admin staff. We do have flexibility for admin staff in terms of the 4-day work week, but most people are on site. We do ask for people to be on site when they're not here. If they do have something to do, they can check with their supervisor, but most people are on site and they don't mind being on site for the 4 days for the 80% of the time. So again, with 85 employees, it's a little different. It's a different model. With a bigger organization, we can talk about that. It would be done in different ways. So one of the things that we realized is that when we went to this compressed these 4-day, um, all our clinics are open the same hours, right? We didn't close clinic hours. We didn't stop any of our evening hours. We didn't stop any of that. We stayed open the same amount of time. The admin work just had to get compressed. So we had to find 20% time. So we started shortening our meetings. We started looking for efficiencies. And one of the big efficiencies we found was these summary of meetings and next steps. You're looking at an example on my right. We still do this. This is me talking to my quality assurance guy. These are just a couple things that came out when we were talking about our patient experience survey and our panelment, our alternative payment methodology scorecard and data integration for these new HEDIS scores, follow-up tasks. These are summary. What you see is an actual summary on the right. These meeting summaries and next steps really help with being able to pay attention during meetings, not worry about notes, not worrying about those other things, and then communicating that. If you miss meetings, you can see the summaries, you know what's going on. We also shortened our meeting time. So our meetings went even from an hour down to 50 minutes, and our shorter meetings went from 30 minutes to 25 minutes, and that made a difference in building internal efficiencies. And the Microsoft Copilot helps a great deal with that in terms of summarizing our meetings and next steps for meetings, always having agendas and creating those agendas. So we've kind of used a built-in AI to help us do those things to get that 20% that we were putting aside in the 4-day work week. So that was kind of the impetus for this particular AI and integrating Copilot or using Copilot. Okay, next slide. Um, the next piece of AI that we got on the train with, and we had been looking to get on the train with this as soon as was possible, that we started hearing about ambient AI for providers, which we're using a bridge. There's lots of ambient AI out there um, for different folks. So I'm going to tell you a little bit more about this journey kind of personally because it kind of feeds into some of the models and what we can use and what we can't use, and I think what is reasonable for a small health center. When we started looking at ambient AI, I was in AI deep, so I was looking at as many different ambient AIs and what were the best, and not only what was the most used, but what was the best in terms of patient confidentiality. There were some AIs that would take notes and transcripts and then create the note and then burn it right away, the whole transcript, so it was gone, so that there was no, so it would eliminate some of those risks associated with, patient confidentiality in some sort of tube or something later on. We looked at different kinds of products or trying to test them. What it came down to for us, though, is that we wanted a product that would integrate with our EHR. We needed something like that. We needed something that was already built. We needed not to be the ones to do all the vetting. We're too small to do that. I don't have the bandwidth. Um, there's one of me, there's one HR person, there's one financial person, there's one operations person, there's one quality person. That's kind of admin. I mean, we just don't have that kind of bandwidth here. So looking at a product that integrates into something that you already have, I think was the way to go, at least for us. It also helped with vetting, right? We talked to our health center controlled network, Aliados Health. They oversee 5 county health centers, big and small, and they knew what was coming up. They knew that this had been vetted, and we took a look at it. Duke, Mayo Clinic, Kaiser, lots of folks are using this. When we were looking at the people and the testing and the results were great, we decided to go for it and implement. So this is how we started. It creates, if you don't not familiar with it, you're just looking at a picture on the right-hand side from actually abridged. Um, it translates, you're basically using your phone, it translates what's going on between the patient and the provider and then writes a SOAP note for you. We piloted with 2 different providers. We piloted with a mid-level that was very efficient at doing notes and getting notes closed the same day. And then we did it with another provider, a pediatrician who was part-time and who was a terrible typer, like this kind of typer, like I used to type, and um, just to see what kind of difference it would make with part-time and an MD versus a mid-level that was efficient. We only have about 6 providers here on our medical side, so those were kind of the 2 groups we tested with. And after a month, we extended to all providers. Let's go to the next slide. Um, so one of the things, what we do, in order to implement a bridge, we again talked to our health center control network. We talked to them about legally what we need to do. We needed to change our consent forms. Our consent forms now talk about the use of AI, and we changed all our consent forms. So even if you're in dental and dental isn't using AI, they're not using Abridged for their notes. It's in that consent anyway. For us, that was just an easier row to hoe with our patients to put it all in our consent across the board. In addition to that, our health center control network said, you need to talk to the patients about this. So when they were handing these consents out, so as soon as we knew we were going with a bridge, we had to start reconsenting everybody that was coming in. So we had the front desk trained and saying, hey, this is I know you may have signed this consent recently, but we're using this new summary product that the medical providers are using to summarize their note. It's helping them so that they can pay more attention to you and they can transcribe the note while it's going on. And you can talk to them if you don't feel comfortable using it. So they said that, then it gets signed, then they go to the back. After the MA is done rooming them and doing what they're doing, the MA also says to the person, by the way, I talked to my provider about this yesterday, and this is how the workflow is going downstairs. Hey, the provider's going to come in. They're going to ask if they can use an AI scribe with you. So just know that that's coming. And if you don't want to use it, you can let me know, or you can let the provider know. And sometimes folks let the MA know. They're like, no, I don't want to use that. And then the provider says, okay. And then they just take notes like they usually do during the visit. And then when the provider's in there, they just say, I don't know if the MA talked to you about this. So we kind of do it 3 times. They're not really heavy lifts with either of those. They were just brief descriptions talking to people, but we did want people to be informed about it. Um, I asked one of our mid-levels yesterday how he felt that's evolved over the years or over this year in terms of people refusing. He said, I would get a few people that said at AI, they're like, no, I don't want AI taking notes at first. And he said he just hasn't had anybody refuse in actually several months now. Um, and he says he doesn't know if something has changed or shifted in general, but he just said he just doesn't see the resistance as much as people saw it before. Um, we did expand it to the other clinicians after 30 to 60 days, and we did not increase slots or visits. It's making up time for the providers. I talked to him, he's like, oh yeah, it makes my day 15, 20 minutes earlier. There is a study out, I think, in JAMA that came out last week, an aggregate study on looking at ambient AI across providers, across all different kind of ambient AI and providers that was done, and it definitely shows time savings across providers and documenting across providers. I have no doubt. I'm just telling you this because I know one of the questions may be, how did I sell this to providers? But that part's going to be pretty easy when we talk about that. So the interesting thing is that that this mid-level said and a couple other providers said is that they had to actually retrain themselves to stop looking at the computer and to start looking at their patients again because they had shifted that right when we got EHRs, and now they had to kind of put the computer aside and actually engage fully with them. So they also keep it up for some prompts and some other things that they want to see, but they don't look at it as much. All right, next. Um, these are a couple of the issues. So I wanted to present these. So I asked him what some of his issues were. So video visits. Right now, ambient AI is used with phones. So if you don't have someone in front of you on a phone, the phone does not have the capability of doing an actual phone visit with that calling them, even if we're calling through our system and then recording them. So he says basically he does phone visits while he's chatting with them. He's repeating what they say out loud so that if he is using the scribe for the phone visit, it's picking up everything they're saying. So I just want you to know that for those of you doing lots of video visits, I don't know how well this works. Other folks may have workarounds or different ways to do that, especially with Abridged. I just don't know. I'm just giving you what he said. Um, Second, we do have folks that come in. We have married couples and other come in and they see providers and they're both scheduled. And so there's a 1 hour block, 2 half-hour appointments or 40-hour block to see both providers. And sometimes when he's talking to them, one person jumps in and starts talking about their diabetes or hypertension while the other spouse or is talking. And he says he has to kindly pause them and say, hey, because unfortunately, whatever they say might pop up in the note and he'll have to scrub that out before, the SOAP note gets embedded into the final note for the provider. So if you're having two people at the same time, you can't really have two of their notes open and use ambient AI for both. It has to be a one at a time kind of thing. Um, he says it's 97% correct. He says 3% of the time he finds something, he looks it over every time. He said it's really good though. So, and he said it's already good and gotten better. So he's noticing that it's even shifted in terms of how good it's gotten. We've seen that with Copilot and some of the other AI that we're using. Okay, next slide. Um, And so our next step into AI, remember, we're doing this kind of hairy nary, and I'll explain about why it's hairy nary in some of the next slides. But we're considering this, which is ThriveLink. It's a Medi-Cal redetermination with HR1 coming down. In other words, we're looking for solutions, right? Um, we're looking for help. We have a big population that is HR1 is definitely going to affect them. The work requirements to some degree, but signing up for Medi-Cal, the paperwork is a pain. We want to keep people enrolled if they can. This new AI agent is telephonic. It's a digital AI. You actually don't need even a smartphone. It will talk you through it on a cell phone. You just answer questions for the AI. We just saw a demo of it on Monday this week. It looks like many of us may go forward in using it. One of the reasons why we're going forward in using it is because our managed care organization for a large area is thinking about providing us some funding to do that over this time period. So it's kind of, it may be if not a freebie, a very low cost solution that we're looking for to keep people enrolled. So here's another use of AI. Again, it's not AI. It's not AI to go out and do referral coordination and to talk to hospitals on the phone for stepping up and stepping down. These are simple AIs to make a difference kind of every day with our patients that we think is going to help for what's coming down the pipe in terms of HR1 for us. So this is kind of where we're thinking our next step is. The reason why, again, we're going for this, it is a vetted AI solution. It's going through our health-centered control network. So when we were on that demo, it was coordinated by our health-centered control network to see, so we could all see it. They're vetting it in terms of its security, its confidentiality, if it checks all the boxes that we need to in terms of legal, and then we can go with it through there. So again, we're not doing it on our own. We're using our network to go forward with this. Okay, next slide. Okay, backtracking. So these are all the things that we've been doing regarding AI in-house. And I just want you to know, we do not have a governance committee. That was probably not the right way to go. We should have set up something first. I'm just telling you, I just didn't do it. I didn't do it because I didn't know enough about it and we didn't have the resources to do it. Right now, we're going back and looking at some resources, and just going on this adventure has hooked me up with resources out of CCI and other places to help with this, creating governance in-house, what we need to do, what are some steps we need to take in-house to vet and to take a look at certain things that we want to pursue and kind of equalize it across what we're doing. So we're going back at this point with leadership and doing some of these things in terms of AI usage, data privacy, risk management, AI ethics, and we're writing policies. Our goal is to write policies for these different things and or integrate them into our current tech policies so that we have them straightforward. So we're ready for our site visit, in a couple of years. We're also looking at building a couple of agents in-house. I don't know, how familiar folks are with agentic AI, but we wanted to try to do something in-house. So this is not patient care related. This is just, we have messy shared drives. We have policies and procedures in different places. We have an HR platform that we do a lot of work with. We're thinking of creating some agents that actually can bring information down to staff and other people that helps them find documents, helps us update things on a regular basis so that people are spending less of their time doing those kinds of things. And we're doing that based on on a survey of kind of admins folks, what they're slogging through and what takes them the most time. And that's why we're still in this, we're looking at what we're going to do based on where the biggest rubs are and where we think we can make a difference. And the last thing is we don't have a model to do this. We've been doing this, we've been including all staff, but we've been doing it differentially. And we want to come up with a model so we can teach AI products and AI to all staff based on their roles, based on what they use. And I can talk about that a little bit more as we go. Okay. Lessons that worked for us. focus on documentation first. Ambient AI and meeting summaries addressed the number one complaint in healthcare, which was administrative burden. For us, I can talk about trying to sell ambient AI to providers. It was not a hard sell once they saw it being used and they saw the other providers having it. It does reduce their burden significantly. Um, we didn't over-engineer anything. We just kind of promoted a culture of curiosity for admin staff. We definitely put guardrails on people. We're just like, look, just like we do HIPAA compliance in-house, so we do HIPAA training in-house. So when AI came out, we asked how many people were using AI on their own. We asked if anybody was using it at work, if anybody was using ChatGPT or anything at work. Actually, we didn't have many staff that raised their hand. A lot of our staff were not familiar at the time, a year and a half ago, with chat or other AIs, and they weren't using it at work, at least that they told us about, but we really don't think that was happening. So we kind of introduced in our HIPAA trainings the concept of what that was, and that if you did plug things in about yourself or about patients, that that would be used for data training, and it was out in the internet, and they understood those concepts. Um, they understand HIPAA. We go over that uh, a lot here just in house because we're in a small town, and so people see each other in different kinds of settings. So they really understand those concepts, I think, to some degree, and that we didn't want them using those in-house. So the curiosity part was more like you never enter any patient identifying information, you never enter personal information into any kind of thing that you're using in-house. And that goes for Copilot and those other things. We don't have, we don't, Copilot is not looking at patient data and doing any analysis for us in-house. But that's not happening right now. Um, and then utilizing your HCCN, just our health center controlled network, if you're part of one, for us is great because we're small. We're very small, right? The biggest health center in our network is giant compared to us. I think they have 12 sites. They serve more than 10 times as many patients as we do. So there's a big difference in terms of what you can build in-house. We don't even have our own IT in-house. We contract for IT services. So using the next step up from you, if that's your HCCN or your PCA, that I think works really well in terms of assessing AI, what's available, leveraging contracts, legal obligations, those kinds of things. Okay. In current AI concerns, this is just the end of where we are right now. My concerns are adding AI is like adding any other kind of tool. They are kind of, most of them are software as a subscription, which means, right, a bridge is another, I don't know, maybe 250 bucks a provider, something like that a month. I think I'll send something out to my CFO and ask him. So you got to take on cost associated with that for sure. If you can get a grant to do it, that's great, but you only get a grant for a while. So you do got to build it in operationally. If each AI tool is another software for subscription, we can't do it. We have to stop somewhere, right? Another concern is we have minimal staffing, knowledge, and capacity in-house to create AI governance. Again, you can see I walked forward with AI, keeping some guardrails on so we didn't put anybody at risk, at least that we know of. I really don't think we did. And it's probably not the best way to go forward. Should have maybe slowed down a little bit. And so we're going back to build those things right now. And then I do want to build this. One of our things is I really want staff. I'm going to retire. I mean, I'm hopefully going to retire. I'm 61, so it may not affect me, but AI is definitely going to affect staff, and I want them to be able to use it as they go, whether they're with us or not. And so building this kind of formalized AI capacity building program for staff is kind of next on our agenda so that people feel comfortable using it as they go, whether they're with us or not, because I want people to be ready for the future, no matter where they are. So I think those are my current concerns. And I think that's it right now. Okay.
Thanks, Chris, for that presentation. You're a really engaging speaker and presenter, so I really appreciated the tone that you approach this with. We have quite a few questions in the chat here.
Okay.
I'm gonna start at the top here. Okay. Could you speak to security and patient trust with data storage and third-party use of patient data? You touched on this a little bit, but could you could you take us back there?
We, yeah, I mean, I think it depends on the patient. So we talked to our providers a little bit about, um, because they had concerns too. So how long does this last? Is this in our phone? Is this in our system? So we did sit down with the provider saying, nothing goes on your phone. There is nothing on a phone. You're in a tunnel. This is recorded and it's on the cloud basically. And after 45 days, the transcript itself is off the cloud and that's no longer there. So we gave them some basic kind of logistics in terms of how things step up and step down. So that if patients had questions about that, we they could answer it, somewhat succinctly or could allay their concerns. And if they couldn't, they would say, look, if you don't want me to use it, they had no problem saying no, like we don't have to use it. So anyway, that's kind of what we did. I don't know if that answers the question for kind of providers regarding that.
For the person that asked that question, I invite you to come off mute if you have any clarifying questions before I move on.
Hi, thank you very much. My name is Carolyn Spice, and Chris, thank you very much for responding to that. One of the things I think about is Savannah Guthrie's mom and how they said that the data was not necessarily stored, but yet they were able to find the data in the software embedded. Anyhow, so that's just it's just a concern, and particularly the third party use of the data. You mentioned that, after a while, a bridge got better, and possibly a bridge got better because it was learning off of the data, perhaps the stuff that was embedded in their whole systems. So I guess there's no real kind of answer or solution to this, but it's just something to consider. And I'm kind of concerned. And don't get me wrong, the ambient AI scribe, I think it's great, and I think this is wonderful that you're doing this and moving along with this. And so I'm not a naysayer in any way. I'm just concerned in terms of, what are some of the guardrails that you mentioned, the privacy, especially with the FQHC population, in terms of making sure that there's trust. In terms of the data storage and making sure that it doesn't go anywhere. I know that you said have Epic with Ocean, and but in the end, it's really about making sure that the providers and the patients are, trust where the data is and how it's being stored. Thank you.
Appreciate that. And I think again, one of the reasons you know, Duke and the Mayo, when we started looking at the people that were looking at those questions as deeply as they were, then that was another reason, we just had to go with who's who's vetted it the farthest, who's gone the farthest with this, who do we trust, in terms of that's going on. But you bring up a great point. It is true. That's the scary side of AI, right? Where's the data going and what's it being used for?
Right. That's great. Thank you very much.
Thanks, Carolyn. Another related question, Chris, is other than the provider reviewing the AI ambient note before signing, are there other monitoring activities for bias, discrimination, hallucination, on the AI scribe documentation, based on risk level? And I think we talked about how you're backtracking into some of this, so maybe that's a part of it, but I wonder, do you have any thoughts?
Again, so we I've asked and it's hard. I mean, we're not doing that. We're not addressing. I'm just going to be straightforward. We don't have the bandwidth to address, is there bias associated with that? All the provider can do is look at the note and see, is this inaccurate? And when you look at these notes, they're not, they actually, they're pretty dry notes compared to what was written by providers before in terms of the depth they're talking about actual people. So I don't know if that is part of them eliminating bias in order to shrink that or not, but we don't see it. There's no one else that's seen that note before the provider's going through it. So the provider's doing it, it's writing it up. Then the provider, before they sign it, they're going. So my understanding is most of the providers are not actually signing their note at the end of the visit. They are stepping back from it for a minute. And after the visit, they go in and then they review the note separately, on their own and then do it because they don't want to, they want to take their time. Does that make sense a little bit to make sure that they see it? Because what they're worried about is if they start doing it like that, they're going to stop paying attention to what's going on in the note. So they're kind of self-monitoring that, but I that's all I've got for you on that. I don't really have anything else. I'm sorry.
Thanks, Chris. Thanks for your honesty.
Mhm.
Few more questions here. There's a question on ThriveLink, and whether or not you are subscribed individually at Winters or through a network.
I think it's going to be a leveraged contract. So the contract is going to be via the network, but well, it'll probably be with us one-on-one. That's how most things work in terms of going back. Um, uh, and it's just we'll probably get a deal because we're going through our health center control network. So we're leveraging all the people that are coming in to get a discounted price, but the actual contract is going to be with us, I imagine. That is how it's going to fall out. That's how it's shaken out with most of these things. So.
Yeah, Michael, that was your comment. You want to jump in?
Yeah, thanks for that, Jessica and Chris. Also, just to follow up, are you looking at it just for Medicaid re-enrollment and recertification, or are you also looking at it for its broader capacity to identify programs? Because I mean, just based on what I've read about ThriveLink, there's more capacity than just the Medicaid piece of it.
There
Thanks.
is, and we like the other capacity in terms of linking them up with other social services and kind of social determinants and other things as well. So, yeah, I mean, that's kind of that's hopefully the win-win part of it, with us. And then we may even look at a revenue cycle product as well that helps support ThriveLink and some of the other things that are happening, but that's not an AI product, I don't think, as we go forward. But yeah, we're looking at both. But to sell it to people, I mean, to sell it to people. I don't mean it, but part of my job is, what is the win for us? And if we can keep Medicaid patients that are eligible on as we go through HR1, then that's kind of number one for us. And we just don't have a lot of, I imagine ThriveLink would be better in a more urban setting. There's less resources to hook up locally that they can hook up with, but it could hook people up to other resources in the community a little farther away from us.
Yeah. For what it's worth, Jessica, this seems like a great opportunity to do a controlled analysis now versus a year from now. Chris's team using ThriveLink to retain patients on Medicaid and re-enroll somebody else in a similar situation who's not, and see if there's any sort of comparisons and lessons learned to do for this. But thank you.
Thanks, Michael. Two questions that are similar, Chris, that I'm going to jump into here is around tracking and assessing the different types of AI and use cases. So how is the organization keeping track of all the AI being used in the org and risk assessment for each? This is coming from Mari, curious about alternatives that are more efficient than manual Excel spreadsheets. So that's the perspective. And then there's a related question from Kelly about just internal reporting and tracking related to AI. So they're kind of similar.
I think, so, so the Copilot and kind of the built-in AI versus the ambient AI versus like I think of ambient AI as kind of a standalone that integrates with our medical record. And I think of the camera as a standalone, right? And I think these questions are really regarding actually the use of Claude or ChatGPT or Gemini or whatever, or Copilot as the case may be. And I want to make that differentiation because what we've seen is the folks in pharmacy, behavioral health, um, dental, and medical are not using kind of AI in their day-to-day work for specific things. They're really not. Again, I'm a smaller organization, right? So most of that work is being done up here on the administrative, and I say up here just because we're on the second floor, is on the administrative level. So there's one, two, three, four, five, six, seven of us. That is kind of it that are using Copilot. And those are the licenses that are purchased for Copilot and using that for other things. If so, that we're not tracking use in terms of what people are doing individually. We'll talk about that when we're meeting. Are you using AI for this? Have you used AI for this? People will say, I did use AI for creating this um the we know it's for our summary of meetings, but it's all self-report right now. We're not tracking it through our IT vendor or any place else. We just know that we put guardrails up and it's kind of best practice to we trust people in-house to do it, which I know is different in different places, but we kind of have a culture of that here. So
Thanks, Chris. We've got a few more questions and running short on time, so let's see if we can get through some of these before we end here. Um, let's prioritize here. Did you have like actual AI trainings that you built in-house, or did you use like an external resource to kind of
I,
get the ball
we
rolling with Copilot?
we've kind of different learning styles for different people. Um so we've done different things where we send out little YouTube videos on how to use something to introduce people to it. And then we kind of have we have younger and I don't want to differentiate. I don't want to be an ageist, but we have some people that are more comfortable using it and just jumping in and doing kind of experimenting with AI to some degree. And so that's what I mean by we need to do this in a more structured way across staff. We need to have a structured way to introduce it to people and to build their capacity to use it. Because what's happened is we just basically have certain YouTube videos on how something works, how they can use it for simple things, how to move forward with it. It has some guardrails and safety pieces of it, but that's it. And then we've let people up here go and use it. And so that's what I want to get to, a more structured way to introduce it to people, to let people have a chance to utilize it and use it in a more structured way. And we're not doing that now.
Thanks, Chris. Let's see. How has your PTO policy changed, if any, with the 4-day work week? Is everything the same
Is everything the same with the 4-day work week?
as far as PTO?
No, we accrue PTO at less. That was one of the things that we changed in the 4-day work week, and people understood that. We did we did 6 months of work before we went into the 4-day work week with a group out of New Zealand and 4-day work week. They've they've done a lot of the research in terms of European countries and states and to help prep. So it was one of the things that we looked at, and we knew we had to reduce a little.
Did you see any increase, decrease, or kind of staying the same around number of days that staff called out of work?
Because we rotate 4-day work week I'm not open on the weekend. So we are open evenings 3 days a week, but I'm Monday through Friday. Everybody's staggered Monday through Thursday or Tuesday through Friday. So those being the biggest call out days, I imagine that we thought we could kill two birds with one stone. And yes, we have seen a decrease of people calling out for sure.
Awesome. And then from Microsoft Copilot, if you're able to share, are you using like the $30 per user per month enterprise level? And is it only select staff that have it, or is it all of your, I mean, I know you have a small,
It's only
you have a small
select
team.
staff.
Yeah.
That's a legit question. It is only select staff because again, so I can't send out an email to staff, all staff, and they'll see it not even that day, maybe a couple, no one checks email like that downstairs. They're messaging either through a Teams product or if they're messaging, they're on Epic platform if they're talking to one another about patients. So they're not even looking. So we just bought licenses for the people that were going to use them. And if and that's where we are right now. And we want to expand that. But again, we want to get that structure in for how we're going to train everybody to do that and go forward before we do.
Thanks, Chris. I'm going to squeeze in one last question here from Anita about you talked about how you're backtracking into AI governance. I'm just wondering if you're also going to be doing that for data governance too, or if you already have kind of a data governance. Um,
That's good. You know where we data governance also goes through our health center controlled network. However, that said, please know that our director of quality is also sits on the governance committee at our health center control network. So it's not like we don't know what's going on in terms of that. So yeah, data governance is one of the things as well. We're pretty tight with that in-house. That's why we don't have Copilot do any analysis. Nothing is out of house right now in terms of that. Um, so again, data governance, is going to be integrated with kind of our AI.
Got it. Okay, I'm going to stop us there so that way Wes is able to take a moment to close us out. But thank you so much, Chris, for joining us, being so candid about your experience at Winters and how you all are approaching this, and really excited to see how that continues with your AI governance work that you all are embarking on in your training. Thank you so much for being here.
Appreciate the opportunity. Really do.